I'm here to introduce our General University Hospital in Prague. Next slide. So you see the city, which is still very nice, even during the COVID period. Unfortunately, now almost completely without tourists. Next one. And we are, of course, very proud that we are one of the oldest universities in the Central Europe. We can't compete with Italy, France, or Spain, but we are very old in terms of Germany and Eastern Europe. So our medical faculty exists from 1348. Next. And here you see in what area we are the first. And next one. And we have a long tradition of very important people working in the university, and among many of them I would stress Christian Doppler, who worked for a relatively long time in the university. And of course Doppler is also very important for everybody who is interested in the blood flow in arterial venous access or anywhere else. Next one. And to mention some important people who played a role in nephrology from our hospital and our university, I would only mention Karol Rokitansky. Next. Next one. He was a prolific pathologist, performing about 15,000 autopsies, and he also described for the first time polyarteritis nodosa in 1851, 17 years before Kussmaul-Meyer. And here you see the picture from his original publication. Next one. Another important person was Otto Kahler, who was the first one who described nephrotic proteinuria in people with multiple myeloma. Next one. Another one was Bardet-Biedl syndrome, described by Arthur Biedl in Prague in 1922. You know now that Bardet-Biedl syndrome is a kind of kidney cystic disease. Next one. Here, next one. And we were always very much interested in cardionephrology, and here is Otto Klein, who was the first who performed 11 diagnostic catheterization with the measurement of cardiac output using fixed principle in 1929 in Prague, and you see the publication from Münchener Medizinische Wochenschrift. And next one. And Jan Brod, who was the founder of nephrology in Prague, was always interested in the role of kidney in essential hypertension and heart failure. And next. And this group, one member of which was Wilhelm Gams, next one, contributed to the development of what is now known as Swan-Ganz catheter, which using thermodilution for the measurement of cardiac output. So only this is to show you the long tradition. Next one. And we started chronic dialysis in Prague in 1955 using this very old Alba artificial kidney. Next. And this is a team. Next one. And now coming to our Prague and PARTS team. Here you see me, Dr. Hrušková, who is in charge of the part dedicated to renal biopsies, Professor Malík, who is in charge of the part dedicated to arteriovenous fistulas. Next one. This is the structure of our department. We are working in a really large hospital. General University Hospital is now the second largest hospital in the country. We have something like 1,000 beds after many reductions, because we had more than 2,000 30 years ago. And the Department of Nephrology was formed and separated from one of the departments of internal medicine 20 years ago. And currently it has two wards which are mostly dedicated, but not exclusively dedicated, to kidney disease. We have also several beds in an intensive care unit. And we have a large outpatient department and both hemodialysis and peritoneal dialysis unit. Next. And we are, of course, University Hospital Center and Tertiary Referral Center for glomerular diseases and vasculitides. We perform each year something like 250 to 320 biopsies per year of native kidneys. There are no transplant biopsies. These are done in another hospital in Prague. And we have even more patients, because some patients biopsied elsewhere are then referred to us and treated by us. We are permanently involved in pre-graduate and postgraduate education. So, for instance, each nephrologist in the country must go through our department. And we are, of course, very much involved in clinical research. And we also have a unit dedicated to experimental research, but this is mostly dedicated to experimental hypertension method, but also to different models of chronic kidney failure. Our main areas of interest are glomerular diseases, then genetic disease of the kidney. Of course, the most prominent is autosomal dominant polycystic kidney disease. We have in our follow-up several hundreds of patients with autosomal dominant polycystic kidney disease. And the third area are cardiovascular complications of CKD and ESRD. Next. And for a very long time, almost 30 years, we are organizing different registries. We have nationwide registry of renal biopsies, which started in 1994, and we have now data on something like 15,000 renal biopsies. The problem is that these are cross-sectional data, and unfortunately we do not know the follow-up of those patients who were not biopsied in our center. Then we have a special registry of ANCA-associated vasculitis, and we have some local large databases with hundreds of patients with lupus nephritis, membranous nephropathy, IgA nephropathy, and also we of course have many patients with rare kidney diseases such as, for instance, fibrillary glomerulonephritis, C3 glomerulopathy, and so on. For many years, more than 20 years, we perform extensive biobanking. So it means that each patient who is biopsied has his serum, plasma, urine, DNA preserved. And we also want to get some follow-up samples, which is of course much more difficult. We were involved in many genetic studies. We were involved in several GVASs in ANCA vasculitis, IgA nephropathy, membranous nephropathy, and we have international collaboration in many areas, namely in ANCA-associated vasculitis, IgA nephropathy, but also in other glomerular diseases as described. And we were very successfully collaborated with ERA registry when we look at the fate of patients with different glomerular diseases when they are already on dialysis, and we published several papers on that. And we are also involved, as I said, in many clinical trials in ADPKD and also in recommendation for the treatment of patients with ADPKD. And we have been involved also in many investigator-initiated clinical trials. Next one. And now something about the Vascular Access Center and Cardiopulmonary Center. These slides were prepared by Professor Malik. Next one. So you see that this is once again the tertiary center working for the whole country. We perform something like 400 to 450 new arteriovenous accesses surgically created, and almost all which are corrected are done in our hospital. So this is something like 50 per year. And we also perform a large number of dialysis and nutrition catheter and many interventions on fistula, such as 1,000 percutaneous procedures. And also, as the patients are regularly followed, more than 1,000 arteriovenous access ultrasonographies each year. Next one. And this is only to show you how it looks like. Next one. Next one. Next one. And this is ultrasound navigated PTA with Professor Malik himself. Next one. And of course, we are interested not only in arteriovenous fistulas, but we are very much interested also in the heart function in patients with high blood flow fistulas, on heart failure in these patients. So this is another program which is also provided for all centers in the country, and we also publish several papers on that topic. Next one. So what we can suggest and what we can provide to those who will come to Prague is that we can also organize nephropathology seminars, which are regularly done in our center and can be done completely on online basis. And they are, of course, done also in person on a fortnight to 1 month regular basis, but can be done exceptionally when there is somebody coming from other country to visit us on more frequent basis. And we have extensive experience with both biopsies, renal pathology, and also, with, of course, with the treatment of the patients. And there is a similar experience with vascular excesses and any kind of monitoring and care for the vascular excesses. So I'm sorry for the technical problems, and thank you for your attention.